So the next session is we're gonna have obviously the legend himself, Dr. Bhide sir. Nami
Round
kafi
of
hai.
applause. Let's go.
Nami kafi hai. So, but
Naami
anyways,
kafi hai.
I need to explain those people who don't know, if there is any who don't know about Dr. Bhide sir. So he is IVF consultant. He done his MBBS and MD from prestigious Sion Hospital, Mumbai, and then he came to UK, and then he finished his MRCOG as well, and he practiced as an IVF consultant. So that is also one of the great job, and he has a lot of other things as well. So he also guides the medical, like the new doctors who are just recently passed their MBBS and who want to come to UK. So he helped them with the PLAB exams. So there are loads of, like I would say, thousands of people like thousands of doctors have come to UK under his guidance. And in fact, what a coincidence that Dr. Sita is Dr. Bhide's student as well. So today we have both student and teacher on the same
Wow.
platform.
Wow.
Yeah.
Wow.
So yes, today Dr. Peter is gonna guide us about COVID-19 and viral infections, like viral infections in the pregnancy, and also like what is the impact of COVID-19 on IVF as well. So there were a lot of couples were asking me here as well as back in India that they are recently married, so whether they shall plan the pregnancy or not. So some part of the discussion will be 18 plus. So listeners need to make sure.
Everybody is 18 plus, Vaibhav, so
No,
don't worry about
because
that.
afterwards, once it go to YouTube, yeah.
Yeah, no, that's fine. Yeah, that's fine.
Yeah.
As a matter of fact, the youngest person around is Vaibhav. So Vaibhav, you want to put your fingers in your ears now, please. इसके बाद जो होने वाला है वो adult certified है. Vaibhav, it's ladies and gentlemen, it's so wonderful to be able to talk to you. Thank you so much for being, and we'll have a quick summary of viruses, COVID and other viruses in pregnancy. That's my area of COVID isn't, but general viruses in pregnancy, all gynecologists have to deal with those. So Vaibhav is not just a wonderful person and a great consultant, but also not just a great businessman, very sharp businessman. But he's also a marketing expert. So he says, Dr. Bhide, can I advertise your session as saying he is going to advise you about COVID and sex? And that will make the hall full. So, and then I said, okay, fine, I'll discuss that sex part right away. He said, no, keep that for the last, so that people wait for the whole session. Otherwise, the minute they get what they want, what they have come for, they will switch off. So I have to applaud Vaibhav for his not just his cleverness, but also his marketing attitude and general perception and understanding the world. So first and foremost, I can make this session very small by telling you that we know hardly anything about COVID-19 and its influence on pregnancy. So that means for the next 45 minutes, I'm going to talk entirely stuff that doesn't relate to COVID.
That's fine.
Because we don't know this. It's called a novel virus anyway, something new.
Yes.
But the principles of viruses and pregnancies is a very interesting thing. And based on the knowledge that we have about how viruses behave in pregnancy, and in general, what do they do? That will give you an awareness about what is the worst that can go wrong, or how nothing may go wrong. And that is the whole purpose of this talk, is to try to reassure you on many counts, based on what knowledge we have about viruses in general. So I thought that might be the best way to go about doing this. So let's take the first point here. How does a virus bother a gynecologist, or for that matter, a population that comes to a gynecologist obstetrician for their health checks? So now, not so long back, the world hadn't heard about the Zika virus. It is not like a new mutation. It has been there. mainly in Southern America or South America. And that suddenly came into light because we noticed that women who were pregnant and who had Zika virus infection ended up having children who had microcephaly, which means a small head, and a few other problems. Then they found out that all of them had febrile temperature, febrile episodes, and they had the Zika virus, and they were all positive for that. Now, suddenly, in my IVF business, before I start treatment, I will ask my patients, have they been to anywhere in South America? It was to start areas around the Amazon. But now, because of the close links of Portugal, then we started over even Portugal at all. Then Portugal and Spain are not so far in being together. So we started saying maybe to Italy and Spain. Basically, we are all scared of the Zika virus because it causes serious problems. Ebola virus is another thing we ask for in today's IVF practice. But in general, if you look at the problems that can be caused, first of all, any viral infection can cause problems to the mother. So what are the examples of mother getting seriously unwell because of a viral infection that she gets during pregnancy? And the classical example is, say, chickenpox. Now, all of us have had chickenpox as when we were kids, but there are some people who do not have chickenpox as a child. And if such an adult, a woman who's also pregnant, will get chickenpox, there is a risk that she will actually die. And this is because when you are young, chickenpox is limited only to the face and the body. And it will come in crops, and there is little scabs, and you scratch. Apart from that, nothing serious happens. But if you get chickenpox as an adult, pregnant or otherwise, you will start getting blisters in your mouth. You will get blisters all around. You'll have high fever. You are in hell. And if you're pregnant, the hell is worse. And it can actually cause pneumonia, pneumonitis, which can kill you. So we have a report of deaths caused in pregnancy, and chickenpox in pregnancy is a common problem. The same problem in India is with hepatitis A. So hepatitis A you get as a child, nothing happens. You just get kavil, jhali, all that, and you stay for a week or 2 or 3. Then you don't eat a bit, you get a little yellow. That's it. End of your problem. But if you get as an adult and you're a woman and pregnant, there is a high risk, or a good risk, not high, but there's a significant risk of getting acute hepatic necrosis, and that can kill you. So that is one problem to mother. Next problem is problem to the child, and problem to the child can be two ways. If the virus happens towards the end of this, you can be born with the virus, and that will stay with you for a long time. Now, if you know that there is a high risk of hepatitis in China and in India, China more than India, how do they get it? And they get it from their mothers when they are born. A very high incidence of hepatitis B in China, and it gets transferred to the child when the baby is in the womb. And this is a chronic carrier status. And that, of course, has long-term complications for the child. But there are worse complications if the child gets his problem when it's in the first trimester. And the classic example of these infections in the first 12 weeks, that is when you get your organs formed, organogenesis. And if you get viruses like cytomegalovirus, so if that is a common virus, happens in adolescents, and that virus, if the woman gets it when she's pregnant, can cause serious problems to the child. This child will then get problems with the organs, with the heart, with the brain, microcephaly again, and a few other issues, hepatitis. And the child doesn't have a great life ahead of that. Think about rubella. Rubella is a very common, not common now because of the MMR vaccine, but when rubella or German measles, that caused serious problems, heart conditions, lung problems, problems with the nervous system. So viruses can affect the child in the first trimester, that's terrible. And also some of them can affect in the third trimester, that's not good either. Look at HIV. One of the biggest transmission routes of of HIV in India is from the mother to the child. And in that case, there are two types of such transmissions. We call it horizontal and vertical. Vertical means it comes from the mother into the placenta, into the baby, and there is not much you can do about it. But the other transmission called horizontal transmission, which means the secretions are there in the vagina, and when the baby is being born, the baby will get infected, just like any other person with a biological touch with the woman would get infected. So this is called horizontal transmission. HIV is known for its horizontal transmission, and hence it can be avoided going to the baby by doing a cesarean. Hepatitis B, on the other hand, is known to be a vertical transmission. So whatever you do, you are not going to stop the child from getting hepatitis. Hepatitis B we are talking of. The child will always get hepatitis B because it comes from the mother to the placenta to the baby. No choice. So in terms of coming back to the corona thing, we hardly know. The youngest child to have been diagnosed with corona is a 3-day-old child, and that's in India. And this, we don't know whether this came from the mother at the time of delivery, whether it came, it is unlikely the mother had corona 9 months ago. So whatever happened must have been in the last month or so, which means whether it transmitted to the child before delivery or during delivery, we don't know this. But that is a case. We'll get more cases. We'll find out more about that. So at the minute, I'm just qualifying our ignorance about COVID and pregnancy. We don't know whether it's a vertical transmission or a horizontal transmission or entirely incidental transmission. Somebody coughs in the room and the child gets it. So these are all the things about viruses and pregnancy in general. So this brings us to another area about understanding viruses and pregnancy. This is called the difference between something called primary infection and secondary infection. Yeah. So what is primary? Primary is when you get that viral infection for the first time. That's called a primary. And if you get it again, whether you get it from outside or whether you get it from reactivation about that infection from within, it's called secondary. So you could call the primary, secondary, and reactivation. Let me explain. The first time you are exposed to the virus, you have no immunity against that virus at all. And that is called a primary infection. And then you develop the first antibodies called IgM and the second set of antibodies called IgG. IgM are called the acute antibodies. IgG are called the long-term protective antibodies. But you didn't have either of those before the virus hit you first. Now, by chance, you get exposed to the same virus again 5 years later, and you get some type of infection. It's called a secondary infection. And it's not such a bad infection because you already had it once, so your antibodies are already there. Some element of protection. But in terms of obstetrics, about the child being affected, the worst damage is caused when it is a primary infection, not a secondary. So take, for example, herpes, or take example of measles. You don't get so much of a problem, or chickenpox. You don't get so much of a problem if the mother had the infection as a child, and today she has a second infection because she met a little child with measles or met a child with chickenpox. The secondary infection is not such a big deal, but primary is. So whether this applies to coronavirus or not, we have no clue. But this is to make you little understand something. Whilst we are on the topic of viruses and reactivation, I might remind, you may have heard about something called shingles. So what is the shingle story? So shingles is nothing. If you get chickenpox as a child, and then the chickenpox attack subsides, that virus is called varicella zoster. You get that attack, classically crops of lesions and all that. Now, when the attack subsides, the virus doesn't leave your body. The virus stays in your body, but it stays in the nerves. And these are called neurotrophic viruses. Now, some of the viruses, other viruses, like to stay in the blood. And these are called leukotropic viruses. And the classic example is HIV. HIV stays in the white blood cells. And rabies will stay in the brain. And this zoster viruses will stay in the nervous system. Varicella zoster, chickenpox will stay there. Now, what happens is suddenly this child has become 50 or 60 years old and gets diabetes or gets some type of a stressful problem, and the immunity goes down. The minute it goes down, the virus will flare, and that is called shingles. So when you have the oldies, 75-year-olds, in winter the stress is too much, they will start getting lesions on their ribs. This is called herpes zoster intercostalis, or they will get lesions on their eye area called herpes zoster ophthalmicus. What it means is the virus can reactivate. It is there in your body. So it's not secondary infection, but reactivation. So the same problem, we have no clue whether coronavirus is going to stay with you and come up later or not. I'm just trying to tell you what all can go right or wrong when we talk of viruses and the human body. So, we got these examples of viruses that stay dormant, and whether corona behaves in that way, we are not very sure. Coming back to the first question, can I have sex? Now, just 2 days back, somebody told me on WhatsApp that Baki sari industry down hai, but the sale of condom has gone up. And I thought, wow, this is very interesting. It also tells me that people have a lot of self-belief, this self within themselves. I will need all these condoms. And number two, they seem to not be trusting electricity supply and Netflix.
Well, it's condoms and toilet paper, which is out of stock nowadays.
Well, because toilet paper is because you hear somebody, my dear friend got COVID and you start getting diarrhea uncontrolled. That's
so they see like they say one person has a COVID and 100 shits.
Rest of get shit scared. But coming back to this, is the question. Somebody said, "Can I have sex?" And then my primary question is, do you have somebody to have sex with, or is it like a DIY job? So if it is DIY, who's stopping you? But and if you're in isolation and you have a partner, a consenting adult, and you're in the same isolation zone, now please don't tell me that you bought these condoms and now you're going out to the neighborhood, sort of, spreading joy. So, अगर वो नहीं हो रहा है, and if you're cozily parked where you are, in my terms, we used to call them husband and wife. Today, nowadays, there are so many different relations. Live in, live out, my friend, just a little better friend, whatever his issues are. But if you are a regular person with this, jokes apart, if you are regularly having sex with that person, then effectively you are sharing your ecosystem. So I don't think it's a big deal for us to worry about whether you should have sex or whether condoms are a good idea or what type of positions you want to have sex in. I don't think it's such a big thing. You're going and sitting and eating across. I hope you're having dinner with the same person as well. So in which case, sex is not the only way coronavirus gets transferred. There are even simpler ways to do that. So I think the question is it's not a serious question, especially because this is hardly HIV story. That you need to do something more than HIV. We spent all time convincing you by having a conversation with an HIV person doesn't give you HIV. Holding HIV person's hand doesn't give you HIV. In COVID, is the other way around. Not having sex doesn't prevent you from getting COVID from the person. So even holding hands is bad enough. Which reminds me of a wonderful WhatsApp I got the other day. HIV was far more civilized than COVID. At least jo karega wahi bharega. In COVID, even if you just hang around, you're getting this. So I don't think you need to worry too much. If you're friends with somebody, you're sharing time and you're sharing dinner, you're already in the same COVID zone. But now the more important question comes is about fertility. So COVID's effect on fertility, our fertility clinics are now closed. So we've stopped doing IVF. As a planned procedure, the only IVF we do is when somebody comes with cancer breast and we want to preserve her ovaries on her fertility, we want to preserve her eggs and embryos. Only those things are urgent and emergent. the rest of the cases are planned, and we have stopped doing IVF for the last 10 days. So only the cycles which are running, we are finishing those. But in another week or so, I'll be unemployed. So that's the. But you're absolutely right. There are enough couples who are talking to me saying, "Can we try naturally? Can we?" And I think it's okay. I don't think we don't have solid information one way or the other. So there is no reason to believe that this is going to cause you serious problems. The corona type viruses are not known to cause fetal abnormalities or something like that. So there is no point in worrying too much about it. But if you are so conscious, what happens is couples get a little nervous and conscious. If they say, if they want to sort of think about it too much, and the fact that the minute they get pregnant, they're going to start worrying and do scans every third day just to check if the baby is abnormal. So, usse better hai, you might want to wait a bit. Who stopped you from waiting a little? But if things happen, I don't think you need to get too anxious about it or too nervous about it. It is, if you look at the type the family coronavirus belongs to, or COVID-19 belongs to, it is unlikely that it is going to have very serious repercussions or effects on the baby. But I've already explained to you the principles. What are the examples of viruses troubling babies, and how do viruses trouble women in pregnancy? There is no doubt that this is all true. Pregnant women have had, I was reading a report, pregnant women having COVID virus do not seem to be at any higher danger compared to non-pregnant women. This is, I just read this last month. But again, COVID is only a 3-month invention. So we don't know much about how it affects. But I've given you examples wherein a virus can be terrible to the mother. That's classic example is measles or hepatitis A. COVID doesn't seem to be in that category as of now. So we don't need to, it's good enough, fair enough to say, don't worry too much about it. Now, there are the reason why we have stopped doing COVID thing is we do a lot of cryopreservation. So there is sperm and we preserve sperm. There is eggs, we preserve eggs. Embryos are commonly preserved. And the whole thing is the whole system can get contaminated.
Right.
We are very conscious about that. So what it means is, suppose I'm sitting in the lab and half our embryologists are Spanish and Italian, and somebody coughs around the medium, that the COVID virus can be then sealed and locked for the next 1 year, 5 years, or 10 years. Because it's not, minus 93 degrees is not going to destroy the virus. That's what we store the sperm. That is a temperature we store at. Eggs, embryos, minus 193. So virus will not get destroyed. Now, will it cause a problem when we bring it out again? Will it cause a problem to the embryo? Now, we don't think that embryo should be affected by a COVID virus. And the reason is the COVID virus requires a receptor. And in your first lectures, you must have heard about the receptor for COVID virus, which is an ACE, angiotensin converting this receptor is used by the COVID virus. So if the ACE receptor is being used, the embryo doesn't have ACE receptors. So in that sense, we should be okay to not worry about COVID affecting embryos as a primary site of affection. So that is our reasons for believing, but it's not to say that it won't happen. We'll find out it is also attaches to something else. We'll find out later on. But at the minute, as the knowledge we have, ACE receptors are not present in embryos at that level of 100 cells and all that. So we should not be too worried. Besides, suppose our solution for such problems is very easy. What embryologists do is we wash embryos with medium, and if the embryo itself will not have the COVID, but the medium may have COVID. So the answer to that is very simple. We say our solution is dilution. So the minute we wash the embryo 10 times, the original medium has gone. So hopefully, if there was virus in the medium, it will go. And normally you require a quantum of virus to give you a problem. By any chance, somebody could pick just one virus and throw it at you. It is not going to affect you. We expect it not to affect you. You have to have a quantum of, this is called the minimum infective load. To give you an example, you heard of HIV virus, which is a terrible virus, and hepatitis B, which is not very good either. But HIV has a worse reputation. But to get infected by HIV virus, you require a lot of blood. So if there is a nail and a patient has HIV, the nail hits the patient, and the same nail is used to hit you, you will not get HIV, because what is happening on the nail, it's a solid needle or solid object. There is not enough blood sticking onto that nail to give you HIV. To give you HIV, we require a hollow needle. So we have the hollow needle has just taken blood. The blood has been squirted out. Something remains in the hollow needle. You require that much of viral load to give you the infection. On the other hand, if you take hepatitis B and you take a needle, a stitching needle, and imagine how little the tip of the needle is, kushagra, the end of the needle, and there you insert the needle in under your skin, and whatever drop of blood stays at the tip of the needle, that is good enough for you to get hepatitis B. It is not good enough for you to get HIV. So this is the story of the virus being, how infective is the virus and what is the minimum load it requires. Now, corona is a remarkably highly infectious virus. It doesn't require a huge load, apparently, of this. We have heard other stories like, say, smallpox. If you are when it was a disease that bothered people, if you are in the room with a person with smallpox, you will get it, guaranteed. COVID seems to be something with a very high infectivity, but we still don't know the loading dose about that, or definitely, at least I don't have a complete idea about the loading dose. It's unlikely to be. So you need some quantity of the virus to make it work. So all this story was because of the infectivity on the embryo. On an embryo story, we doubt if there will be adequate load to create a problem that will affect the embryo in the long run. So I think that is so much about the knowledge, what we know and don't. I've made some notes. So I'm just telling you, we've stopped our IVF cases and all that. So there we go. I don't know why you gave me 1 hour to talk. The knowledge base is barely worth 25 minutes.
No, sir, there's a lot more.
Yeah, but I don't want this lecture to. I don't want you guys to be good enough to pass the MRCOG one after I finish. Because this lecture is free. The one I teach for MRCOG, I sort of charge money for that. So. If you have any simple questions, please ask. I always tell my students, ask me simple questions. I'm an expert. Please come.
So the simplest question is one of our colleague. He is Dr. Prashant. He's one of the gastroenterology colleague. So he has asked you a question whether you have come across any patients who had previous SARS or MERS, and then they came to you and either like for IVF or something like that. Have you seen anybody having any fetal abnormalities in pregnant women with SARS or MERS?
Oh. That's a very interesting thing. I feel embarrassingly inefficient, because we do not, of all the histories we ask, we don't put a lot of focus on SARS and MERS viruses. And the other thing that happens is, no. The simple answer to that is no. And I'm not even sure whether we have a high index of suspicion for such viruses. Because there are some things that we always ask. Okay, the way we ask history is, do you currently have a problem with fever and rash? Okay. Historically, if you have had a problem with SARS, then probably it's not something that will feature in a big way in the history for fertility. We are quite focused on the problem as it stands now. See, technically, such questions. Have you had a hepatitis infection in the past? We check people for their hepatitis infections. So whether you had it in the past or not, it's not a big deal. If you had it, I will get evidence in my core antibody. that shows you got a past infection. But my interest is not core antibody. It is my interest is in surface antigen. If you have it, and I'm not even interested in the surface antibody to the surface antigen. I don't know. I don't care about your immunity. I just want to know, are you infective or not? If you're infective, then I will keep your embryos in an infected separate container. That is my only approach. So coming back to SARS virus, it's not a big question on our history list, not for fertility treatment. Prashant, should I be asking that question?
Yeah, no, actually, thanks for the pleasing lecture. No, actually, I had two questions. Actually, one is actually trying to answer it. I'm just wondering if there is any data, miss. You say like you normally don't consider to check whether they have previous history of SARS in the past, whether that leads to infertility. And second is like, the previous pandemics or epidemics happens in the past. Whether you come across any published data or studies showing there is a risk of fetal abnormalities, the pregnant ladies who had the infection that time. I was just wondering if there is any such data, but I think Vaibhav had just sent a couple of articles. I was just reading through it, but I just wonder if there is any articles you know of or anything.
As I said, at my starting of my talk, I said our current flavor of the month are Ebola and Zika. We are quite hot on those two questions. Have you been to those areas? Have you been to South America? Now the question starts getting stupid. Until the time it was Brazil, life was easy. Argentina. Now we started asking, have you been to Portugal? Have you been to Spain? Have you been to Tenerife? And if the question comes in winter, then every person in UK has been to Tenerife or Ibiza in the previous 3 months. So that the whole Zika virus thing became a joke because everyone has been to the to the areas of this. But we still ask that question, and I think it has got a lot to do with your liability and culpability more than of course we can check out for Zika. That's the next step. But that once the prevalence of the virus becomes so much, then such specific questions lose their importance. Is my feeling. I'm hardly an epidemiologist, but when the prevalence was so low in the world and very high in Brazil, the Zika question made sense. My suggestion this time is everybody's been to areas wherein there is some Zika influence. Why don't you just do a test for everybody? If you're so concerned, I take that angle. But to answer your original question, I have not read. I should go and check up on SARS and MERS. Have you by any chance?
I just put two articles. They're the only one which I found in the past.
Sorry, say that again.
I have just put those two articles in the comment box. So these are the only two articles which I came across. I think these were published in somewhere in early March or late February. So these were about pregnancy and like MERS and SARS.
Besides, the other thing, Prashant, I feel is viruses which have a very short sort of a span of clinical activity are unlikely to be a cause of serious this problem. Is my feeling, but I'm not an expert on this matter. Generally, viruses with a longer stay in the body are the ones that are going to cause you a little more problems. So that is why. But I'm just. This is more of a.
No, that's absolutely true. Yeah, that's absolutely true. And actually, so far we have seen a lot of different strains of this current COVID infection. I mean, some of the cases we have noticed that the virus is now, we found longest, I think it's 56 or 57 days in the body as well. So I think because of this genetic mutation, the viruses keep changing. And I think we may coming across the COVID infection, which may stay longer than the current, the 7 days initially was, now it's 14 days. But we have came across certain cases which actually they stayed for 56 to 60 days as well. So I think the virus strain is changing. It's quite adaptable to human system. and it's quite genetically modifying itself. So I'm just wondering if there is any going to be a kind of long-term follow-up for those people. Might give a good study data actually.
So I have one question. So yeah, so this question is asked by one of my anesthetic colleague from India. So what he was telling was because he was a little bit worried and scared because we have seen the recent data like the intensive care audit in UK. They found that most of the people were young population who died rather than the old population in UK. But obviously, after 70, we have a DNR, so hardly they come to ITU. And this data is only specifically for ITU. So his question was because one of my friend's girlfriend also died as well. She was ITU registrar. So the question was whether for storing the sperms or storing the eggs, as you said earlier, that you have stopped it. But those guys who are concerned and worried that they may not live, and they wanted to, to have some to keep them preserved for their family purpose. How what is your approach? So if somebody want to preserve their sperms, and if they think that they're frontliners and they may not survive this pandemic, it's not skeptical approach. What we have seen in Italy and what we are seeing in China, so it theoretically still possible that if you're a young guy, you're a young doctor, and you might die. So, but you want your sperms or like no sperms and eggs to be frozen. What is your approach? Because as you said, like you have stopped it, but
Well, I'll see the problem is I can take the question, and the question is quite a real question. I'll give you a supporting evidence. It's a real question. Up till now, uh, I've pretty much gone. I'm still in the age, of course, but I've moved from the heart attack age to the stroke age, and yet I've never written a will. But the other day, I sent a mail to my lawyer, writing a little brief note about what happens when I die. So, what? And I've been flying. I've been flying. I had a huge air mile thing in my plab days. I used to go to India 3 times, like 18 times a year. I never made a will. I never thought I would die. Today, I really feel, yaar, kuch bhi ho sakta hai. So the risk that somebody actually worries that I may die and my genes will not get propagated. Remember, the desire to propagate your genetic material is even bigger than the desire to eat food. And we know that because elephants, I didn't know that until David Attenborough told me that elephants will fight for 3 days and 3 nights without eating just to get the right to propagate their genes, the bull elephants. So I take your question entirely. Now, coming to the practical point of it. First of all, the labs are closed. But if somebody were to come and say, boss, I need to store my sperm with this, there is a process for storing sperm, and it first starts with a counseling. And at the end of the counseling, it is probably, I don't know how many of them will survive, keep on thinking the same way. Now, would we regard this as a case of, if somebody walks in the clinic and says, I've got testicular tumor, and boss, I want to save my sperm, the urgency or the risk or the sort of attention I'll pay to him versus somebody comes and says, boss, I'm very worried about dying. Can you store my sperm? I would think, I have a suspicion that we won't weigh the two things in the same way, or we won't perceive the risk as the same thing. Having said that, who am I to decide what is his risk perception? So if somebody really comes and says, I want it because I'm paranoid about this, I'm worried about this, then by all means, we will save it. But the general idea is these social or elective freezing, we have stopped. Now, coming to the women storing their eggs, that is even more difficult because the process not only requires counseling, but also requires preparation and everything that goes on for at least 2 weeks of preparation. Then you get a period, and then we start and treat you for 2 weeks. And then we have 3 or 4 scans. Now, I don't know anybody who's a frontline worker will have so much time to come to do these scans with this. And to be honest, I'm not sure what inclination clinicians and nurses will have to sort of entertain such a request. But I'm sympathetic that if somebody really feels, ki boss, I need my genes to be in this world after I go, then that fear is genuine, that desire is genuine, and we should respect it. I, I would but there will be some discussions in the clinic, that's for sure. I don't think we will say, okay, come Monday. I doubt it'll happen.
Right.
They'll say, boss, let me have a chat with the team.
Yeah. Fair enough. Prashant, your voice is breaking.
Hello.
My voice is breaking. Don't hear it. Hi.
So just on a background, because I'm a gastro, and recently we got a British Society of Gastroenterology guidelines about these endoscopies. So we have stopped for the next 3 months doing any 2 weeks rule or any urgent endoscopies, just because of the recent evidence suggested from Japan and Italy that there is increased secretion, basically release of bacteria, this virus into the GI tract. And the endoscopy has become quite high risk now. So they have stopped doing for next 3 months, despite there is a 3% risk of missing a cancer on endoscopy, and people with quite red flag signs, we're still not doing it. So even from national guidelines point of view, we have to stop it just to accept the risk, basically. Just to add a point on a similar situation. There will be a big thing going on, actually. Means people gonna have serious trouble, gonna miss cancers, are gonna miss operations, may end up having a tertiary cancer, whether they have avoided with a simple surgery. So I think because of this pandemic, there gonna be a lot of ethical issues going to cause.
You're so right. And besides, I was just mentally calculating. There's a 3% chance of missing this. The collateral damage of the pandemic is going to cost more lives than actual death by COVID-19, because we are not doing routine colonoscopies, we are not doing gastroscopies, we are not doing most operative procedures. Bleeding PR is no longer a life-threatening matter. Which means that in the next 3 to 6 months, besides, you start working in 3 months or 6 months. Okay, I said this to a non-medical friend. He was asking, "Oh, when will all this come back?" And it was middle of the night, and I wasn't thinking straight. I just wrote him the fact. I said, 3 months at least, and 6 months most likely. And that he probably panicked. He probably had a need for a toilet roll. He was hoping that after 21 days, Modi says, everybody start doing what you're doing. This virus, this problem is not going to go away in 3 months. We are going to be struggling with the aftermath, and then there will be another small little peaks that keep on happening. So 2020 is a gone year. Now, with that type of story, the restructuring of the screening program, very ambitious screening program for the GI. At 55, you'll get a one-off colonoscopy. Then you'll get your every whatever 2 years. Very ambitious and very demanding program. I don't think that it is going to be off rail, and it is going to, as a result, cause late detections, advanced early cases moving into advanced story. This pandemic is going to cost more lives on the collateral side, rather than dying on the respirator.
That's definitely
true. Anybody having questions with the pregnancy and other things?
There we go. I have always been known. I didn't check whether Jay Tehsildar is online now. He was yesterday.
He is not joined today. Of all the
Today-
days, today is the only day when he has not joined.
He's the first absentee.
Well, I said the minute he heard Dr. Bhide, he said, "I don't have time until 12 midnight." So I would be so keen to tell Jay that first, see, I finished at time.
Right. So, sir, we're gonna discuss like Sam. Shall we
Yeah.
take the today's like the national numbers, and what we'll do is we'll also cover a couple of questions which were asked earlier. So we'll go through the international data and national data first, and then we'll discuss further.
Yeah.
So this is
But
the
we'll keep it
today.
to 15 minutes, Vaibhav, okay? We'll
Yeah,
hard
yeah,
stop at 11, okay?
yeah. So, so far we have 1,093,000 patients all across the world, out of which 60,000, like almost 58,000. So 58,000 are dead, with a mortality of so 20%. So why I'm saying 20% is the closed cases. So once you say closed cases, that means either they are dead or they are recovered completely. If you see those who are currently active cases, so we should not count that into the mortality. So actually the true mortality is 20% rather than 5%. So we can say as a range between 5 to 20. We don't know what's going to happen with the mild condition guys. So that is worldwide. We'll discuss about India and UK as well. So in UK, we have 38,000. In last 24 to 48 hours, there are new 4,400 cases, and 684 died. And so far as India is concerned, we just had a starter. So we have 2567 as a total number, so 24 new cases. So as we were discussing earlier, in down the line on the probably first week of May will be the period where the actual peak will start in India, and while we'll have the monsoon coming, we might see more number of cases when the monsoon will be there. So somewhere down the line, 6 to 8 weeks will be the critical time for India. And so far as UK is concerned, so Sam, as we discussing earlier, like where we are on the chart. So on the bigger chart, so although we are seeing here that we are at 30,000 range, and the curve is going is following the specific pattern. But as we predicted earlier, probably in down the line in next 4 weeks, we will be reaching from 30,000 to 150, and the mortality like the dip probably between currently is I think how much is it? Currently is 3,600, which we predicted 4 weeks ago, which will be like in down the line in 3 weeks going from 4,000 to probably 20. I don't know. Let's say depending upon how we fight the battle.
Yeah.
Yeah. And yeah, so there were a couple of questions were there. So I'm just gonna go through a few questions. So one of yes, sir.
Can I just quickly share a thought, which the reason for sharing it is, I don't know if everybody thinks like that, or am I way off the mark? This whole story of giving more investigations or offering, what does India need? India needs more investigations. When does it need it? It needs it now. All these, I just keep on thinking, I'm not sure whether all the investigations that we do,
Mm-hmm.
since you have no answer to the problem,
Yeah.
it's nothing but in an Indian scenario. Okay, coming back, 65 million population in this country, and they
Mm-hmm.
want to do 100,000 odd investigations every month or something.
Mm-hmm.
You extrapolate that to India, that touches to a few lakhs, like 25 lakhs or 50 lakhs a month. And there are people like this Kamini Kapoor or somebody who will get 5 tests.
Mm-hmm.
So the amount of money you spend on these tests, it will be great for epidemiology. It will be wonderful to know which way we are going, but probably practically, you know exactly which way you're heading. And
Yeah.
your answer to Corona is to keep people locked in their houses, whether it takes 3 weeks or 3 months. No, I initially I was advocating. I wrote to in many places saying India should be doing more investigations, and now the more I think about it, I'm thinking in a place like India, it's a waste of money.
Yeah.
When
And
you don't have ventilators, Whereas you don't have the expertise, we don't have the doctors to manage ventilators. What are you going to do?
Yes,
So
very true, sir.
keep them locked.
Hmm.
That,
Because if you see like the costing of the tests, it again it has its own dynamic as well. Like the previous PCR test costing between £18 to up to £100.
yes.
In India, the cap is 5,000. New tests are coming. They have their own sensitivity, specificity, as we were discussing earlier, and everything has his own pros and cons. But the most important thing is the frontliners. If you don't have the ITU doctors, if you don't have nurses, then just having mere ventilator lying on the beds not gonna sort it out. You need somebody who understand that how to use it.
I think all the excitement that my lab developed this new test, but we
Mhm.
don't know and I'm very happy and proud that it's a great test, uh, or it has been developed by Indians on their own. Great,
Mhm.
wonderful. Mahindra has developed this ventilator, which is
Yeah.
basically a mechanical way to squeeze the ambu bag. And
Mhm.
all my non-medical friends are getting excited. And then I thought it is nothing but a mechanical compressor of the ambu bag, and the modern intensivist requires a far more complicated ventilator. It is like somebody. If I tell my son tomorrow I'm going to buy you a new car, and by the way the car is called a Dukkar Fiat, how excited is he going to be about that? This is 1965 model. So you can't give a fixed respiratory rate type of a ventilator that Mahindra model has shown. I thought
Yeah.
it is very good for national morale.
Mhm.
We're all excited about it, but I don't think. No, I'm not undermining the MyLab test. I don't know much about it. But if
Mhm.
that test doesn't have a 90% sensitivity or 95% sensitivity and a great specificity,
Mhm.
uh, it's so let's when the results are out, you want something like that, but even that, how many tests will you do?
Yeah.
Uh, it's a tough solutions to the same problem in a different ecosystem are going to be different.
Mhm.
With India's population, I keep on wondering whether isolation.
Yeah. So one of the our colleagues, so Arya asked the question earlier that because we have seen the two NHS recently died, both of them were their early mid 30s. So her question was, if somebody contracts a coronavirus too intensely, so what that means is if somebody who is positive for COVID-19 and that person's cough in a significant bout and too many droplets go at the same time into the other young person, whether that person is going to die irrespective of the age, or is there any validity to how much coronaviruses should go into the body uh, so that the person can die or like person can survive? Uh, so
It's your question, Vaibhav. You don't
yeah.
want a gynecologist to answer that, do you?
No, no, no. So basically, to answer that question is, I think it's again same with a viral load. Like viral load is like in a fixed. So it's more like a physics thing that if you have a fixed container, so you have a fixed volume, and uh, so in simple words, there might be. You have a container where there are 1 million viruses are packed together into one thing in one container, and then if that container breaks, it will open up 1 million viruses in that region. So it will shatter and it will be 1 million in that particular location. However, if you have only 100 viruses in the container, and if the container breaks, it will only gonna spread 100 viruses. So obviously, if you are exposed to a big number of volume, like if big volume of the uh, like big number of the viruses, then obviously you are more you will get the chance of getting infection is slightly more than the less number of viruses. But obviously, it depends upon the individual immunity. So even if you have a low immunity, and then even with a low number of viruses, you can still get the infection. In contrast, if your immunity is on a better side, then even with a higher volume, you may not get the similar sort of infection. So it all ifs and buts rather than any specific calculation or any scoring. So I think the moral of the story is that. Sorry. Yes, Prashant, you're saying something?
Oh yeah, no, actually just wanted to add, yeah, as you said, like it's very difficult to quantify the amount of infection you're gonna get worse. So as you know, like you must have seen the video from the one of the professor from Japan as well. So when we cough forcefully, we spread huge amount of millions or even billions of viruses around. And again, it's depend on a immunity response of your body, which again you won't know how you're going to respond. And the mortality we have seen so far, mostly in doctor side, is mostly people from the intensive care unit where they have exposed to huge amount of inhalation. Despite actually, I'm not sure, but maybe they're using the best the mask at the current practice, and despite of that, there is a risk of they are getting a really nasty infection. So it is very difficult to quantify how much viruses you're going to inhale, or if you're going to have continuous inhalation, and how long this aerosol going to stay around you, and how much time you're going to expose to that inhalation. So it is quite wayward. It's quite difficult to quantify basically. But yeah, in broad spectrum, if you inhale huge amount, definitely you're going to get nasty bad infection. But again, it's not really straightforward. Just
Yeah. All right. So.
So good. I think so. We almost 5 minutes to closure. So I guess there are no other questions, right, Vaibhav, for the
Yeah,
session
I
right now?
don't think.
We
Yeah, I
pretty much
think there are no
answered
obvious questions today.
questions.
If there are any, we can put that in tomorrow's one.
Yeah. So good. So I think so. Let's call it a day. So thank you, Bhide sir, for
Thank
your
you.
time and
Thank you so much.
very nice information. I think so.
Yeah.
Everybody learns a little bit every day, and these special sessions have really helped.
Yes.
So having said that, it was a 1.5 hour session, a long one today, but I think so most of them have benefited from that.
Yeah.
And all these sessions are recorded, available on YouTube, so you can go back to there and check on information that you might have missed. And last but not the least, there are some phone calls that go to Vaibhav after 11 o'clock. So I would have a humble request that as much as the concern for COVID is there, if we could limit our questions in the session and not after the session is over, should be very helpful for Vaibhav as well as everybody else who's helping us out. So thank you all. Thank you. Good night for this
Thank you.
session, and take care. Be safe, and talk to you tomorrow. Okay.
Sure. Bye.
Thank you.
Thank you, guys.
Thank you. Bye.